Welcome to our presentation where we're going to talk about shock and vasopressors. The body has blood, particularly red blood cells, that have hemoglobin that carry the oxygen to the vital organs of the body. Providers should remain vigilant for changes in the perfusion cascade. They should apply interventions to avoid shock or end organ failure. We will use this triangle in this presentation to represent the key players involved in maintaining hemodynamic stability, including blood pressure and MAP in the human body. These include the pump, the fluid, and container. Mean arterial pressure is the average pressure in a patient's arteries during one cardiac cycle. It is a better indicator of perfusion to the vital organs than systolic blood pressure alone. A MAP of greater than or equal to 65 millimeters of mercury is needed to provide enough blood to the coronary arteries, kidneys, and brain. In order to calculate the MAP, you could take 2 times the diastolic blood pressure, add the systolic blood pressure, and divide by 3. Or you can simply look at the cardiac monitor. Just below where the blood pressure is, there's usually a number in quotes, parentheses, or brackets. That is the mean arterial pressure. EMS providers used to use the systolic blood pressure as an indicator of the hemodynamic stability of a patient. Now we realize that the mean arterial pressure is a more accurate indicator of a patient's ability to perfuse their vital organs. Let's look at these 3 blood pressures. Which do you suppose would yield an adequate MAP? Let's use our big calculator. 90 over 60, 60 times 2 plus 90 divided by 3 gives you a MAP of 70 millimeters of mercury. 84 over 40, 40 times 2 plus 84 divided by 3 gives you a MAP of 55 millimeters of mercury. And 100 over 36, 36 times 2 is 72 plus the 100 divided by 3 gives you a MAP of 57 millimeters of mercury. So despite the fact that you have a systolic blood pressure on one side of 100 and a systolic blood pressure on the other of 90, the 90 over 60 actually has an adequate MAP. Before administering pressors, you need to fill the tank. So you will be administering lactated ringers or sodium chloride to your patients prior to the administration of pressors in most cases. When administering fluid by gravity, you need to select the proper drip set. This particular drip set is a 10-drop set. What does that mean? Every drop that comes out is a specific volume of fluid. So for every 10 drops, that will equal 1 milliliter. If you're going to administer fluids by gravity and you decide to put an extension set on, the hospital staff will be extremely pleased. There is a micro drip set and a macro drip set. The micro is narrower in diameter than the macro that has a wider diameter. This chart is from the Emergency Medicine Education Project. It illustrates the different size catheters and the flow rates of each. The size of an IV catheter is representative of the quantity of steel needles side by side within 1 inch of space. So, for example, in the case of a 14-gauge IV catheter, 14 14-gauge needles would fit side by side in 1 inch of space. The needle that you choose is dependent upon 2 things: the vascular integrity of the patient and the hemodynamic stability of the patient. Some patients need a lot of fluid very rapidly, and others just need a little bit of fluid to push them to a safe margin where they have an adequate MAP. A good, solid assessment is important, and solid provider judgment should always prevail. ALS units should carry commercial pressure infusers. However, if they are not available, you may use a blood pressure cuff and wrap it around the infusion bag. However, be careful that the cuff or the meter attached does not fall on the patient. Some students require memory aids to be successful. So here you go. The pressors paramedics in Rhode Island are allowed to administer all end in INE, including dopamine, which actually ends in mine. These are a list of pressors carried by EMS agencies in Rhode Island. Phenylephrine, which primarily affects the alpha receptors, norepinephrine, which primarily affects the alpha receptors but does have influence over some beta 1 and beta 2, dopamine, which primarily affects the dopamine receptors but also has influence over beta 1, beta 2, and alpha and is dose dependent, and epinephrine, which affects the alpha, beta 1, and beta 2 receptors. Phenylephrine acts upon alpha receptors, resulting in vasoconstriction. This results in increased peripheral vascular resistance and thereby increased blood pressure. Norepinephrine acts upon the beta 1 and beta 2 receptors, resulting in increased heart rate and increased force contractions. It also acts upon the alpha receptors, resulting in vasoconstriction and increased peripheral vascular resistance, thereby increasing the blood pressure. Epinephrine acts on beta 1 and beta 2 receptors, with more beta 1 increasing heart rate, increasing the force contractions, and has some alpha properties, which acts on vasoconstriction, which increases systemic vascular resistance, thereby increasing blood pressure. Dopamine is divided into 3 different dose segments. Less than 5 micrograms per kilogram per minute acts on dopamine receptors, increasing splanchnic blood flow and renal vasodilation. EMS doesn't often use it at that rate in Rhode Island. Dopamine, 5 to 10 micrograms per kilogram per minute, acts upon beta 1 and beta 2 receptors, increasing heart rate, increasing force contractions. Dopamine greater than 15 micrograms per kilogram per minute has some beta, but primarily exerts its effect in alpha. The alpha exerts itself with vasoconstriction, increasing peripheral vascular resistance and blood pressure. Any dose greater than 20 micrograms per kilogram per minute is predominantly alpha effects. Hemorrhagic shock is caused by excessive bleeding or hemorrhage. Bleeding can be external or internal. External bleeding is easier to discover and usually easier to control with direct pressure or even a tourniquet. With internal bleeding, providers can make it exponentially worse through the administration of fluids unnecessarily. Administration of too much fluid can lead to hemodilution, increased pressure with increased bleeding, and disruption of clots that are attempting to form. The vessels become leaky, allowing those white blood cells to leave the vasculature and to look for that infection. As those become leaky, the vasculature increases in diameter. So you have a gross vasodilation, which is going to lower the blood pressure, and a leaching of fluid from the vasculature. This is in addition to any fluid losses that may be present due to vomiting or diarrhea, or even marked and prolonged tachypnea. So septic shock is a container problem. As the container enlarges, the blood pressure drops, and can be a fluid problem as well, with loss of fluid from tachypnea or other insatiable losses such as diarrhea, frequent urination, or even perspiration. So your patient needs pressors and they need fluid first. Septic shock with hypotension usually requires aggressive IV fluid management and replacement. We utilize lactated ringers as opposed to normal saline, and we utilize 500 milliliter boluses to a maximum of 2 liters to achieve a desired outcome of blood pressure greater than or equal to 100 millimeters of mercury or a MAPL greater than or equal to 65. If after 2 liters of fluid there is still persistent hypotension, you can either go to a push pressor dose of epinephrine or phenylephrine, or norepinephrine is preferred as an infusion, or you can use dopamine, epinephrine, or phenylephrine as an infusion to achieve that desired outcome. To simplify cardiogenic shock, there's a problem with the pump. There's a problem somewhere with the heart. That could be a non-STEMI or a STEMI, valve problems. It could be cardiomyopathy, but it's a pump problem. Anytime you're about to administer large volumes of fluid to a patient, you should always check the lung sounds and make sure they're clear, but particularly in cardiogenic shock. Remember acute decompensated heart failure. That's a lung problem that's caused by a heart problem, of heart that's in some degree of cardiogenic shock. So make sure you're checking those lung sounds. You can start with a bolus of 200 milliliters of lactated ringers and move on with norepinephrine or dopamine. Your desired outcome will be a blood pressure greater than or equal to 100 or a MAP of greater than or equal to 65. Neurogenic shock is caused by a brain or spinal cord injury and results in decreased vascular tone and an increase in parasympathetic tone. The blood is unable to be propelled through the vasculature properly because the tone of the inside of the vasculature is off. One other difference between neurogenic shock and other types of shock is bradycardia that ensues. This is due to the influence of the parasympathetic tone as the sympathetic tone is decreased. Your desired outcome for treatment of neurogenic shock includes a blood pressure greater than or equal to 100 systolic or a MAP greater than or equal to 65. You're going to check those lung sounds, administer lactated ringers, 500 milliliter boluses up to 2 liters total, then move on to pressors, including phenylephrine, norepinephrine, and dopamine. Any EMS provider that sees one of these in the truck, you may not know what it is, but it's a dial flow, so just throw it away because they don't use them anymore. IV medication may be administered via IV infusion pump or via push pressor dose. There are certain medications which require an IV infusion pump to administer. EMS providers should be familiar with the IV infusion pump that is employed by their service to perform this. For the purpose of this presentation, we're talking about dopamine, epinephrine, norepinephrine, and phenylephrine. These must be administered via IV infusion pump. However, epinephrine and phenylephrine may also be administered via push dose. These are some examples of medications which may be administered by ALS providers in Rhode Island without the use of an IV infusion pump. Push dose phenylephrine has an onset of action time of 1 minute, duration of action time 10 to 20 minutes, adult dose 50 to 100 micrograms every 2 to 5 minutes, and a pediatric dose 5 micrograms per kilogram, max single dose 100 micrograms every 5 to 10 minutes. Phenylephrine push dose preparation is rather easy. You take 1 vial of phenylephrine, 10 milligrams per ml. Utilize a 3 milliliter syringe with a needle and withdraw 1 milliliter, 10 milligrams of phenylephrine. Take that preparation in the syringe and needle and add it to a bag of 100 milliliters normal saline. Label that bag for safety. Take that same bag, utilize a 10 or a 12 milliliter syringe and needle, and withdraw 10 milliliters from the bag. You now have 100 micrograms per milliliter. Make sure that you label that syringe so someone doesn't confuse it with a normal saline flush. Push dose epinephrine is going to have an onset of action of 1 minute with a duration of action of 5 to 10 minutes every dose. The adult dose is 10 to 20 micrograms every 3 to 5 minutes, and the pediatric dose is 1 microgram per kilogram every 3 to 5 minutes. In order to create an epinephrine push dose preparation, you're going to take epinephrine, formerly known as 1/10,000, 1 milligram in 10 mLs. You're going to take the glass vial out, pop the plastic cap. You're going to use a 3 ml syringe with a needle, inject it through the rubber stopper, and withdraw 1 milliliter of that drug. Set it aside safely. The next step, you can do 2 things. You can take a 10 milliliter normal saline flush and empty out 1 milliliter, leaving you with 9 milliliters left in the syringe. Or you can take a 10 ml syringe and just draw up 9 mLs of saline. Either way, you're left with a syringe with 9 mLs of saline. You're going to take your 3 ml syringe with 1 ml of the epinephrine and slowly inject it into the syringe containing 9 mLs of saline. And now you have your preparation. Make sure you add a caution sticker to that syringe. If you do not have epinephrine 1 milligram per 10 ml premix, you can make it using epinephrine 1 milligram per 1 ml. You're going to take a 3 cc syringe with a needle, pop the cap, take out the 1 milliliter, 1 milligram of epinephrine. You're going to take your syringe, get rid of 1 milliliter, then you have 9 milliliters of saline in your syringe. And you're going to add that 1 milliliter of 1:1 epinephrine, and that will be the proper 1/10,000 or 1 milligram per 10 ml mixture, which is the same as the Burstajet. And you can continue on with your push dose preparation from there. Thank you for taking the time to view this presentation. Rhode Island EMS providers should always refer to the Rhode Island statewide emergency medical services protocols and/or medical control when considering treatment options.